We are live.
Good evening. Welcome to today's iFocus lecture 55. Today we have Dr. Akanksha. She has completed her MBBS from Government Medical College, Karnataka, followed by DNB from Sri Shankaradeva Netralaya, Guwahati. She later pursued her fellowship in Cornea and Anterior Segment at LV Prasad Eye Institute, Hyderabad, and is currently working as Associate Consultant at Center for Sight, New Delhi, in Cornea, Cataract and Refractive Services. She has multiple publications in peer-reviewed journals and presented in various conferences. Today, she'll be talking on a very common and an important topic, blepharitis and Meibomian Gland Dysfunction. Welcome, ma'am, and please take over.
Thank you, Harika. Okay. So are the slides visible?
Yes, ma'am. Perfect.
Okay. So thank you, Harika and Team iFocus for giving me this opportunity. So like Harika said, the topic that I've been given is blepharitis and Meibomian gland dysfunction. Now, why is this topic important is that though we feel it's a very simple topic, it has a lot of intricacies in the pathology, the management, and as general ophthalmologist, this would be the most common thing that a patient would come to you with. So it is, and since the patient is so symptomatic with this, it's very important that you recognize this in the clinic and it's adequately treated for you to have a happy patient. So we've always been taught this, that you should know what is the normal to be able to identify the abnormal. So beginning with that, this is the normal structure of our eyelid, which we have come across many times. So anybody from the hot seat, though it's all labeled, but do you want to explain or read out the picture shown?
Ma'am, this is a picture of eyelid. It shows an anterior border, gray line, and the posterior border. The anterior border is rounded and the posterior border is relatively sharp. And anterior to the gray line, we'll have eyelashes. Posterior to it, we have Meibomian gland orifices,
Okay.
through which the ducts of the Meibomian gland will open.
Okay. Where are the Meibomian glands actually located?
Ma'am, in the tarsal plate.
Okay, and the gray line divides it into some lamellae?
Anterior and posterior lamellae, ma'am.
Good. Yeah.
Posterior will be consisting of tarsus and conjunctiva, and anterior will be the skin and orbicularis.
Right. So that's correct. She's correctly pointed out most of them. So this is a more detailed picture where it also shows you the levator palpebrable muscle. It also shows you the tarsus. And like I was saying, the Meibomian glands are a part of the tarsal itself. It also shows you some eyelashes and the glands that are surrounding these eyelashes. So they are the gland of Zeiss and Moll. They both also have a role in maintaining the tear film stability. I'll just be discussing their role in ahead in the future slides. So what would also be important at this point from your exam point of view would be all the muscle origins and insertions, anatomy of the orbital septum in itself, and the various glands in the eyelid. So gland of Zeiss is also a sebaceous gland, but it secretes by a holocrine secretion, whereas glands of Moll are sweat glands, where the primary mode of secretion is that it's an apocrine gland. So the sebum that is secreted by the gland of Zeiss has self-sterilizing properties, as well as the secreted lipid. It contains vitamin E, and it prevents the aging process and maintains a healthy skin barrier. The glycerol that is produced by these follicles has some role to play in skin hydration, and the dysfunction of these glands can cause insufficient hair cell function as well. The Moll gland primarily has a role because it has secretory components such as immunoglobulins, mucins, and lysozymes. So they do have a preventive role for preventing any infections, and it's a very vital component for the immune defense against any microorganism. Now, it's important to know the history of whatever we are studying today or understanding about. So this is Henrik Meibomian. He was the first person who actually described the structure of the Meibomian gland as back as 1666. And what he described was a basic structure, but what we have come to understand now after various studies is the detailed structure. So the gland that we were discussing, which is present in the tarsus, basically has this structure, where, as you can see, there are various ductules that are formed, which are connected to the secretory achini. So this secretory achini has some epithelial cells, which by holocrine secretion They will secrete meibum into the ductules, which then will connect to a central duct. As the arrow points, the meibum would move upwards and towards the opening of the meibomian gland, which we discussed would be just anterior to the mucocutaneous junction. So they are primarily tarsal glands. And why are they important? Why are we discussing so much about these glands? Because they are going to produce the lipid component of the tear film. And as you know, that's a very important layer of the tear film, and it has a role in maintaining the tear film stability as well. So they are sebaceous glands, as we discussed, with holocrine secretions. Now, the number of glands that are present is very variable in different studies, but the average we say is that there are 25 in the upper eyelid and close to 20 in the lower eyelid. Primarily, all the studies have said that the number of glands in the upper eyelid are more than the lower eyelid, but the average number may vary from studies, from different studies. So again, histopathologically also, you can see that there's a central duct, and these glands are primarily secreting their secretions into the central duct, which then comes onto the lid margins. Now, the secretions that we're talking about, what does it essentially contain? So it is a mixture of various lipids. The lipids are of various classes. It can have wax esters, cholesterol esters, fatty acids, so free fatty acids, and in smaller quantities, polar and non-polar lipids. So it's basically just a mixture of different types of lipids, and all of the lipids have different qualities and different melting temperatures. So when we talk about the tear film, you know that there are three layers. The layer that we'll be concentrating on today is the lipid layer, which has some polar and some non-polar components to it. So the polar component, 30% of the polar component is made up of sphingolipids. And what happens in meibomian gland dysfunction is that this sphingolipid increases in quantity. Now, when the sphingolipids increase, the metabolites of sphingolipids such as ceramide also increase. And these ceramide components make the melting temperature of the secretion higher. And therefore, the meibum that was supposed to be in a liquid state starts now becoming more denser. It does not melt. It does not remain in the liquid state. And that is how it starts obstructing the glands. So this is the basic pathology that is happening. Now let's go a little deeper into understanding the meibomian gland dysfunction. So the International Workshop on the Meibomian Gland Dysfunction defined this as a chronic diffuse abnormality of the glands that is characterized by terminal duct obstruction or qualitative or quantitative changes in glandular secretion. So each word has an importance here. Why they called it diffuse was because if there's a localized obstruction, what we see clinically as chalazion, that can occur, but you would not have an ocular surface problem because of that. And they also added in the definition that it can result in alteration of the tear film and symptoms. So the patient would be usually symptomatic with eye irritation, clinically apparent inflammation, and ocular surface disease. So Meibomian gland disease in itself can have congenital causes, neoplastic causes. One of the subtype of a Meibomian gland disease is the dysfunction. And even when the Meibomian glands are not functioning properly, they could be divided into low delivery and high delivery problems. In the low delivery, you have primarily hyposecretory, where there is no terminal obstruction, but the production in itself goes down either due to primary reasons or due to secondary reasons, such as use of medications. Whereas in the obstructive type, you do have terminal duct obstruction. So the meibum is being produced, but because of the obstruction, it is not being able to be released into the tear film or the lid margin. Again, this can have various causes, which could be cicatricial or non-cicatricial. The high delivery problems are where it is a hypersecretory. That means the quantity of meibum may be more, but the quality of meibum or the contents of the meibum may be altered. So in the end, this would all lead to ocular surface disease, including dry eye and clinically apparent inflammation. So like I said, viscosity of the meibum increases. Viscosity is basically a measure of what is the resistance to outflow. So now when the viscosity increases, in simpler terms, you can understand that the resistance to flow of the meibum increases, and therefore there is more retention of the meibum. Hyperkeratinization of the ductal epithelium occurs, and this also causes terminal duct obstruction. And following this, When the meibum keeps getting collected in the ducts, it finally starts leading to the gland dropouts, atrophy, as well as decreased secretion. And then what we end up with is called Meibomian gland dysfunction. So there are various, it's not a single factorial disease. There are multiple factors which are involved, starting from the age, influence of hormonal disturbances, environmental factors. They all would cause some amount of hyperkeratinization and obstruction. And like a vicious cycle, this keeps going on. The stasis of the meibum leads to dilatation again, leads to atrophy, leads to low secretion of the meibum. Of course, there are other factors like contact lenses and the aging process, as I discussed, which also affects this. Now, we have understood the pathology, but what would the patient come to you with? So the patient would complain of redness, irritation, burning, itching, crusting of eyelashes, loss of eyelashes. Sometimes they do complain of blurring vision. If the patient is a contact lens user, they may give you the history that we are not tolerating the contact lens well. There may be photophobia, increased frequency of blinking, and sometimes even a recurrent hordeolum, a chalazion which is not resolving. These may all be symptoms of the Meibomian gland dysfunction. When you look at the patient, you can see prominent blood vessels crossing the mucocutaneous junction. You can make out frothy discharge on the lid margins. The Meibomian orifices would show you some pouting or plugging. And if in some cases, if you apply pressure over the eyelids, you may see turbid fluid or thick cheese-like material coming out of the openings. There could be thickening and scalloping of the eyelid margins. And like I said, trichiasis and chalazion may be there in most severe cases. Now, Meibomian gland dysfunction in itself has some risk factors and some diseases that it's associated with. So dry eye is a very interesting component of this because the dry eye is said to have a cause as well as effect relationship with Meibomian gland dysfunction. How that happens is that it is said that patients who have dry eye have less lysozymes and immunoglobulins, and therefore they have more bacterial growth on is how they develop Meibomian gland dysfunction. The other school of thought is that Meibomian gland dysfunction in itself, because causes a loss in the lipid layer, causes more evaporation, and therefore the patient ends up having a aqueous deficiency dry eye. So it has a cause as well as an effect relationship. There are also many dermatological conditions which have been seen to be associated with blepharitis as well as Meibomian gland dysfunction. So 95% of patients who have seborrheic blepharitis, which is a type of blepharitis which we'll be discussing, they also had dermatitis. And even in patients with Meibomian gland dysfunction, a subset of them, they did have dermatitis or rosacea. Now, what is rosacea? It's usually seen in middle-aged women where they have symptoms of facial flushing, telangiectasia. They can even have pustules and scarring over the face, which you can see clinically also. They complain of recurrent redness of the malar area. If you see that the patient has all this, you have to refer them to a dermatologist because this disease can get triggered by some antigenic stimuli or some environmental conditions, and they would need treatment for that to help with the MGD as well. Isotretinoin, which is a commonly used drug for acne vulgaris, it has been shown that it increases the levels of Staph aureus that is present on the lid margins, and therefore this also has an association with the patients developing Meibomian gland dysfunction. Giant papillary conjunctivitis, usually seen in patients who use contact lenses, they also, because of the contact lens constantly irritating the lid margins and the inner surface of the palpebral conjunctiva, they also sometimes develop Meibomian gland dysfunction, and then the patient becomes intolerant to the use of contact lens. Now, if a patient comes to you, it's very important to ask a detailed history, look for the symptoms and signs, and how the time of day when symptoms are worse is important is usually if the patient is having just an aqueous deficient dry eye, they would say that the symptoms get worse as the day progresses. So they would complain of tiredness, itching, redness more in the evenings. But patients who primarily have a blepharitis or have a Meibomian gland dysfunction are always worse in the mornings. You can also ask them about any exacerbating conditions, any systemic diseases, or systemic and topical medications like we just discussed, if they are using isotretinoin, if they are on hormone therapy, if they are using any contraceptives, all these may also have some role to play in the Meibomian gland function. Examination should be complete starting from the face. Look at the malar skin, look for any hyperemia, telangiectasia, scales or ulceration on the eyelids. Always remember, for a patient of blepharitis or Meibomian gland dysfunction, the examination is complete only if you do also, along with the general examination, a tear film analysis. So the dry eye test should also be included as a part of your examination. Always remember to look at the cornea, stain it with fluorescein, look for any marginal infiltrates, look for any epithelial defects, and also look at the palpebral and bulbar conjunctiva for any signs of the giant papillary conjunctivitis, as well as look for any cicatricial changes. Once your clinical examination is done, with the recent advancements, we now have Meibography available with us, where we can actually get a picture of the Meibomian glands and we can visualize them. It also helps to explain to your patient how exactly advanced the disease is, and so that he or she can also understand what is happening. So earlier, the Meibography systems used to visualize these glands through illumination of the tarsal plate from the skin side, and that is how they were detecting abnormalities in the gland morphology. But however, the disadvantage was that it used to see only a small area, and the probe that was used was a sharp and it had a hot edge, and therefore arose the rise for having a non-contact Meibography. So with the present systems, we are using non-contact Meibographies, where a normal gland is seen approximately as a linear structure around 3 to 4 mm in length and transversing the posterior eyelid perpendicularly from the lid margin to the opposite edge of the tarsus. So this is what a normal Meibomian gland would look like. You can see the upper lid as well as the lower lid is being visualized. The parallel lines that you see as hyperreflective structures are your glands. Between the structures, you can see some hyporeflective areas. So Areta et al. Very nicely described the various severities. As you can see, the pictures are arranged in increasing order of severity of Meibomian gland dysfunction, where the first picture shows some tortuosity of the glands, but they look essentially normal. If you move to the second, you can start seeing that the hyporeflective areas have increased. Those are the areas of glands atrophy. The tortuosity has increased. And if you look at D, there is hardly any hyperreflective areas you can see. Those are the shortened glands. So Meibography is important because the factors that we were discussing, that with aging, with contact lens use, the morphology and the function of the glands can get affected. And with contact lens use, it has been seen that this does not even reverse if the contact lens is discontinued for 6 months. Even in patients with allergic conjunctivitis, distortion of these glands has been noted. So to have a clear-cut diagnosis of what severity of Meibomian gland dysfunction these different factors have caused, it's very important to have a Meibography with you. This is again showing, like I said, shortening of the Meibomian glands in the lower eyelid. It's very clear. And in the upper eyelid, some areas of dropout as well as dilatation and tortuous glands. This is a patient of allergic conjunctivitis, which shows increased distortion. So it's very classical in allergic conjunctivitis to see a lot of distortion of the Meibomian glands. Now, there are also advanced techniques like ocular surface analyzers, which study the surface reflection pattern. They use interferometry and they give you the dynamics of the lipid layer as well. So you can visualize the Meibomian glands, but along with that, you will also have a dynamic idea about the lipid layer that is present in the tear film. And this will, with the pattern that you get from the reflectance of the tear film, would be compared with a reference, and you can see how much of lipid layer is present, and then you can quantify the severity of the dry eye also. So this is what a printout of the ocular surface analyzer would look like. It would give you the non-invasive tear film breakup time, where you don't need to stain the patient with fluorescein. Using interferometry and the reflectance pattern that you get, you can quantify the lipid layer present. There you can measure the tear meniscus height, and the Meibomian gland function and the structure would also be seen. And you can in detail see how much of meibomian gland loss has occurred in the upper lid as well as the lower lid. So Ereta et al. Also suggested that in decreasing order of importance, the factors that should be seen are the ocular symptom score, which is usually seen as a questionnaire, the lid margin abnormality score, the Meibo score based on the Meibography, and the tear film breakup time. And these can help to distinguish this dysfunction from any normal condition. And if you use combination of these factors, then you are at a higher chance of diagnosing MGD correctly. Now, if a patient has meibomian gland dysfunction, your goal would be to improve the secretions, make the patient more comfortable, and improve the tear film stability also. So classically, the medical management has been described initially, where the use of antibiotics was suggested. Again, antibiotics can cause a dual mechanism. When the antibiotics are used, they are not used only for their antibiotic effect. As we will discuss, they are also used for some of their anti-inflammatory roles. And why the antibiotics are important is because bacterial colonization on the lid margin in itself produces a lot of toxic products, including bacterial lipases and other pro-inflammatory products like MMP and interleukins. So these together overall cause inflammation of the ocular surface. So it's important to have a control or have a check on the bacterial colonization of the lid margins. So the antibiotics commonly used include groups like tetracycline, which is bacteriostatic. But like I said, the main role here would be to have an anti-inflammatory effect. It will act on the lipases, the free fatty acids, all the pro-inflammatory mediators, act on the neutrophils as well as the lymphocytes, so that the inflammation surrounding this goes down. Macrolide antibiotics like azithromycin have also been routinely used. They are available in topical as well as oral formulations. The topical for the ease of convenience is preferred. And also, since oral azithromycin has a documented side effect of causing cardiovascular arrhythmias in patients with QT prolongation, it should be avoided if there's a history of cardiovascular disease. So topical would be maybe the preferred choice in these cases. Now, moving on after antibiotics, you need to also have anti-inflammatory drugs. The first FDA-approved drug for dry eye disease was cyclosporin A 0.05%. This is a calcineurin inhibitor. Calcineurin is the main product which leads to activation of T cells, and therefore the cascade of inflammation goes on from there. So if you can inhibit the calcineurin, the T cell activation stops, and therefore the inflammation also comes under control. It has been seen that use of cyclosporin improves the patient's redness, improves all the signs that were seen, as well as the quality of the meibomian gland secretions. The only disadvantage being some patients, most of the patients say that there is some stinging, and some patients may not tolerate this at all. Now, the recent drugs like lifitegrast, which is being commercially available as Zidra 5%, has also been FDA approved. This is lymphocyte function associated antigen antagonist. It also blocks the T cell binding to ICAM molecule. The ICAM molecule is basically present on the inflamed epithelial cells, and because this blocks the adhesion of T cells to these receptors, the inflammatory cascade is inhibited. Corticosteroids, though they have an anti-inflammatory role, most of the studies suggest that they may not be needed in meibomian gland dysfunction unless there is some acute inflammation where you may use them for a short-term role. Or oral supplementations like essential fatty acids with omega-3 and omega-6 and fatty acids have also been recommended. Again, there are not many studies supporting their role, but it is still to be seen how much they actually affect the meibomian glands, but they are being suggested as a mode of treatment for chronic cases. Now, moving on from the medical management, initially mechanical intraductal probing was also being done, where physically the glands were being dilated with probes so that the secretions increase. This may be a little uncomfortable to the patient, and now we have electronic heating devices available which are being preferred as the mode of management. Now, why are we talking about electronic heating devices, or why do we recommend warm compresses to these patients? Like I said, normally the melting point of this meibum is 19 to 32, and your normal lid temperature remains at around 33 to 37. So this remains in the liquid state. But because the disease in itself and the ceramide metabolites that we talked about initially cause alteration in the melting point, a higher temperature is needed for the secretions to melt. And that is why we are trying to give warm compresses or have a heating device. Now commercially eye masks are also available, which you can microwave, they become heated, and then the patient can apply them on the eyelids. So it's an easier way of doing the warm compresses. There are also devices such as LipiFlow available. This is a thermal pulsation system. It basically has a lid warmer. It has plates, insulated lid warmers, which can apply warm heat waves to the lid, as well as an eye cup that intermittently keeps applying pressure from the outside. So you're heating up the secretions and then they are being pressed out. So in a way, you're trying to remove all the collected secretions from the gland. Intense pulsed light is a therapy where high intensity light ranging from 500 to 1200 nanometers is applied on the lower eyelid or the upper eyelid, on the skin of the lids basically. This has dual mechanism of action. So one is, yes, it is going to cause some heating up and the role of warm compresses and melting of your secretions. But it has also been seen that this light of this high intensity gets absorbed by the oxyhemoglobin that is present in the inflamed vessels which are present on the lid margin. And this causes thrombosis of those blood vessels. So when the vessels get blocked, there is obviously decrease in the inflammatory mediators that are being got to the lid margin, and that helps in reducing the disease severity. It also reduces the epithelial turnover, and in cases where there are Demodex mites, it may also destroy those as well. So this is the machine where there is a mask as well as a probe available, and these deliver basically the high intensity light to the eyelids. So this is in a summary the treatment of Meibomian gland dysfunction, which was suggested by the international workshop itself based on the staging. So they said that in mild stages or early stages where there may not be many symptoms, but there are some clinical signs and there is no ocular surface staining, you can inform the patient about eyelid hygiene, inform them about lid compresses, lid warming. But if you see that their patient now has minimal to mild symptoms, has gone to stage 2, some clinical signs are visible, and you are seeing some ocular surface staining, then you need to, along with the eyelid massage and the eyelid warm compresses, you need to add some artificial lubricants, move on to topical macrolides, give topical lubricants, and you can consider oral tetracyclines as well. When the disease signs and symptoms are moderate, you can add now anti-inflammatory therapy as well. And if there are marked symptoms, then you have to obviously go all the way and give everything starting from lubricants, the anti-inflammatories, the antibiotics, and explain to them about importance of warm compresses. Possibly you can even try the IPL therapy. So this was basically about Meibomian gland dysfunction. Now it's a bit of an overlap when we come to blepharitis. I'll explain why. Because blepharitis in itself is a chronic ocular inflammation that involves mainly the eyelid margin. And it's a very common cause of ocular irritation, which would come to your clinic. Now it's one of the most common ocular conditions affecting almost 47% of patients seen in the clinical setting. And though we may tend to ignore it, but for the patient, it's very important because the patient experiences a lot of symptoms because of this. So classically, we described blepharitis and classified it into anterior and posterior, where the anterior was said to involve the eyelid skin, the base of the eyelashes, and the follicles, whereas posterior was said to affect the Meibomian glands. And that is why there was kind of an overlap in the sense that it is described in many studies as well as Meibomian gland dysfunction itself being synonymous with posterior blepharitis. But that may not be always true because MGD is a type of posterior blepharitis. However, posterior blepharitis may have other causes as well. So In the anterior blepharitis, the most commonly that we describe are the staphylococcal and the seborrheic blepharitis. And in the posterior, the most common one definitely is Meibomian gland dysfunction. So in staphylococcal blepharitis, you see scaling, crusting very typically, and erythema of the lid margins and collarette formation. This collarette formation is nothing but the hyperkeratinization that we were talking about. They start collecting, as well as the dead cells at the base of the lash follicle, they start collecting around the lash follicle. And if it is a chronic thing sometimes, and if it's more severe, you can also see ulceration of the eyelid margins. In these cases, and in the severe cases, if you stain the cornea with fluorescein and look at the cornea, you can see some marginal infiltrate. Sometimes you can see punctate erosions, and sometimes you can also see corneal neovascularization. As compared to staphylococcal, where you have more of crusting and scaling, seborrheic blepharitis has more greasy appearance. The eyelashes will be matted to each other, there will be greasy scaling, and they, like we discussed, they may have seborrheic dermatitis of the eyebrows and scalp as well. And usually seborrheic blepharitis will also have a posterior component. So it may also have Meibomian gland dysfunction in addition to just the anterior blepharitis. So this is how a picture of seborrheic blepharitis would look like. So this I have already discussed, that posterior blepharitis, MGD may be one cause of it, but there could be infections and allergic causes. So it should not be used interchangeably, the two terms. Now, usually coagulase negative staphylococcus or Staph aureus are the main etiological factors. They have some toxin production. They get colonized over the lid margins and they produce toxins. And these antigens can also cause keratitis because of inflammatory response to the antigens present. So the marginal corneal infiltrates that you see, or sometimes you see flectins, they may be due to the response of the antigen that is present on the eyelashes. If you see a patient of blepharitis, always ask for a history of any previous surgery, any trauma, including mechanical, chemical, or radiation injury, any eye surgeries like blepharoplasties. You can ask for a history of recurrent styes and chalazions because that's very common, and also ask for any history of dermatological diseases such as rosacea, atopic dermatitis, etc., and if they are on any treatment also systemically for the same. Most of the symptoms would be overlapping with the Meibomian gland dysfunction that we discussed, mainly the symptoms that you would expect a patient of dry eye disease to have. They may also, they are irritation, redness, discomfort, foreign body sensations, and sometimes if they have allergic eye disease or they have a coexisting aqueous deficiency dry eye, these conditions also worsen when the patient develops blepharitis. So when you look at a picture, you will see matted eyelashes. You can see erythema of the lid margins. There would be collarettes. Sometimes there could be swelling, poliosis, and in the severe cases, there may be ulceration and scarring as well if you're looking at the anterior blepharitis. But if you're talking of the posterior blepharitis, like we discussed in Meibomian gland dysfunction, you would see pouting or plugging of the Meibomian orifices. You would see some frothy discharge, and you would see thickening of the lid margins. If the patient has rosacea, you can also see a lot of telangiectatic vessels, dilated vessels that are running up to the lid margins, erythema, and the papules and pustles over the face. So in rosacea, like I discussed, initially you may see just facial flushing, but then it progresses sometimes to having phymatous changes, and the patients may even develop a rhinophyma, which is the most advanced stage. So in a female of 30 to 40 years, who has some hyperemia of the malar area, always keep rosacea in your mind. Now, the marginal staphylococcal marginal keratitis that we were discussing, it's very important that if you see any peripheral corneal infiltrates which you feel are moving circumferentially and they are more in the area where the eyelids are touching the cornea, always look at the lashes, because you may see that the primary cause of developing these infiltrates may be the eyelashes itself if the patient is having blepharitis. And then the treatment of blepharitis would become very important for managing these patients. So this is something you have to keep in mind. Now, there are no specific diagnostic tests for blepharitis. It's a clinical diagnosis, but of course, sometimes cultures may be indicated if the patient is having recurrent blepharitis and there is very severe inflammation or not responding to therapy. For Demodex blepharitis particularly, the epilated eyelashes may be seen under a microscope and the diagnosis may be confirmed, though they can also be clinically diagnosed. So blepharitis remains primarily a clinical diagnosis. Confocal microscopy to look at the lid margins and the Meibomian gland is also being studied, though that may still need more research in that topic to have a very substantial role to play in the diagnosis, because clinically when something is so apparent, so many tests may be unnecessary. Now, what you have to be careful about in a patient of blepharitis is also that it's not always just blepharitis. In a patient who has chronic blepharitis, which is unresponsive to therapy, especially if one eye is involved, you may keep a possibility of carcinoma also. Look for the amount of cicatricial changes in the conjunctiva of the affected eye. And in case you have a suspicion of carcinoma, then obviously a biopsy would be needed to confirm. But at least if you have it in mind, that is how you will know that you need to look for other things as well. And in the conjunctiva, if you're seeing any signs of cicatrizing disease, then you have to be suspicious of mucous membrane pemphigoid, and then conjunctival biopsy with immunofluorescence would be needed, and then the management of that would be different. DLE or discoid lupus erythematosus are also rare causes of blepharitis, so they also need to be kept in mind. Now, the treatment of blepharitis, you have to insist to the patient eyelid cleaning, eyelid hygiene, because that is the primary thing. Warm compresses and ocular hygiene has to be stressed. Lid scrubs, either with just warm water, or you can advise even soft shampoos, baby shampoos or diluted baby shampoos. And the antibiotic and the anti-inflammatory drugs, like we discussed in Meibomian gland dysfunction, would have the same role here as well. But the main information has to be shared with the patient is about eyelid hygiene. So ask them to use moist compresses, try and clean the debris and the secretions, and do this for at least 5 to 10 minutes and at least once daily. And the eyelids have to be cleansed thoroughly. To do this easily, they can use a cotton bud, which is soaked in dilute baby shampoo. And you have to ensure that they incorporate hygiene into the daily routine, because blepharitis is a chronic condition. It will not go away just in 2-3 months. You have to explain that it can keep reoccurring. So eyelid hygiene has to be a part of their daily routine. In the antibiotics, the similar antibiotics like tetracyclines and macrolides can be used, which have an anti-inflammatory as well as an antibacterial role. And because macrolides are broad spectrum, they have good penetration and prolonged duration of action, they may be the preferred drugs. Again, steroids can be used in moderate to severe cases of blepharitis, but usually it's recommended to use them only when there is some acute exacerbation. Even if they are being used, try and use a low potency steroid, but for long-term use, there may be no role in, just like we discussed in Meibomian gland dysfunction. Cyclosporin also, there have been various studies where, such as Perry et al., they also randomized patients to receive cyclosporin versus placebo, and they did find that the symptoms were better, the patient was better on using cyclosporin. So if you see any patient with signs and symptoms of blepharitis, first try and see whether it is anterior or posterior blepharitis. If you feel that there, always look at the lashes to rule out Demodex or a crab louse or Phthiriasis palpebrarum infection. If that is out, then you are dealing with anterior or posterior blepharitis. Accordingly, advise the patient warm compresses, eyelid scrubs, start on some topical antibiotics and low potency steroids if there is an acute inflammation, and only if the case is severe, then you can move to systemic antibiotics and omega-3 fatty acid supplementation as well. So like we discussed, Demodex, it is one of the causes of blepharitis. It is the most common ectoparasite which is found on human skin. The most common types are Demodex follicularum, which is mainly in the lash follicles, and the brevis, which is mainly found in the glands. So they act at the base of the lash follicles, they cause cell death there, and because these secretions then collect around the eyelash, what you typically see is cylindrical dandruff around the base of the lash. So when you see cylindrical scales, always have a diagnosis of Demodex in your mind. So if a diagnosis is clinically apparent, then it's okay, but you can also send the epilated lash for a microscopic examination, and the Demodex parasite in itself can be seen under the microscope. The treatment of this would then be to advise tea tree oil of a 50% tea tree oil lid scrubs, and you can advise them to do it at home themselves to eradicate the Demodex, and it significantly decreases the mite counts by 4 weeks, and the itching or the redness that the patient is complaining of, it can decrease. So sometimes small children, they may have this, and they may they will be treated as allergic conjunctivitis for years together. And if you actually do a complete examination, then you can see these cylindrical roughs. And if you advise them the lid scrubs, they would be better in 4 to 6 weeks. So I'm just ending with this, but the hot seat participants, this is just like a spotter for you. Can you tell me what is this?
Anyone? Saloni, Aziba?
Okay, I'm going to point it out.
Louse.
Yeah. So this is the louse. Yeah. So these also, it's very common to see these. So you have to actually look for them. If they are seen, then that is the primary cause of the blepharitis. Mechanically removing them is suggested as the best treatment. Use of petroleum jelly is also suggested, because petroleum jelly seems to block the breathing tubes for these louses, and then the parasite falls off. But if it's possible to mechanically remove them, then that is the best treatment. So always remember that it is very important to distinguish blepharitis and Meibomian gland dysfunction from aqueous deficiency dry eye, because classically all of them are going to have just the symptoms of dry eye. They are all going to tell you that we have redness, we have pain, we have discomfort. The pointers in the history would be worsening of symptoms in the morning, typically in blepharitis, whereas worsening later in the day as the day progresses and evaporation increases may suggest aqueous deficiency dry eye. Typically, blepharitis is a chronic condition, so it is very important to explain to the patient, counsel the patient that it cannot be permanently cured. The patient has to be very compliant with eyelid hygiene and with the treatment regimen. And if they are not responding to the therapy, then in the back of your mind, you have to keep a possibility of carcinoma or some other cause which is happening. You have to look at the conjunctiva for any cicatricial changes and keep an alternative diagnosis in your mind. Thank you.
Thank you so much, ma'am, for such an extensive coverage to the topic. We have few questions in the YouTube and Facebook. If you allow, then we'll go ahead with the questions, ma'am.
Sure.
Okay, so the first question is, what does holocrine and apocrine secretion mean clinically? Like, does it make any difference clinically?
Clinically, no, but pathologically it's described because the glands have various types of secretions. That's how we describe as the holocrine, being that the entire cell is given off in the secretion. Once the cell is given off, it is going to grow back. And in the apocrine, a part of the cell disintegrates and come out. But yeah, clinically, you would not see any difference between the glands or how they're functioning.
Okay, ma'am. The next is how to clinically detect that whether it's a low delivery Meibomian gland dysfunction or a high delivery MGD.
So one way of doing it is that if you press the lids and you see that there's a lot of meibum coming out when you press it, that means there has to be some obstruction which you are now clearing with the pressure. So in that case, you may think of it as a hyposecretory, but with a terminal obstruction. Okay. Whereas, yeah, so that is one way of doing it. But otherwise, there is no other way. Like if it's an obstruction with the pressure, you can get over it, and the secretions will start coming out. If there are no secretions in the glands per se because of hyposecretion, then you will not have a lot of cheesy material.
Okay, ma'am. The next is how does hypersecretion MGD leads to dry eye?
So hyposecretion MGD also means that the meibum secreted is less. Now, when you know that the lipid layer is not there, your tear film is not stable. So dry eye does not always mean breast production. If your tear film is not stable because there's no lipid layer in it, the patient is going to have dry eye because of the absence of the lipid layer.
Okay. Yes, ma'am. So, and the next question is, when we are advising warm compression, then how long should it be advised in any patient? Is there any
Yeah.
clinical criteria to just tell them that okay, 1 month or 6 weeks or something like that?
So like I said, if it is, it's going to be a chronic thing. So initially you can tell them that they can do it once daily for 2 to 3 weeks till they are better. Then you can advise them to at least make sure they are cleaning their eyelids once in a week or once in 2 weeks. So let them not stop it completely, but let them make it a part of their routine practice. The frequency can go down as the time increases and they are better symptomatically.
So it's completely depending upon the symptoms. It's not that okay, 1 month
Yeah,
or
but
3 month duration
yeah,
should be taken.
but they have to make it a regular thing.
Okay,
That is
ma'am.
important.
Okay. The next question is, what all systemic diseases can exacerbate MGD?
So systemic diseases like allergic diseases, patients with asthma have also been seen to have exacerbations of MGD. And by my exacerbating conditions, I meant conditions such as contact lens use, excessive wind, and sometimes active allergic eye disease. So systemically, you may not have a lot of diseases that exacerbate. You can have an association with MGD, but the conditions such as, are they using a contact lens, are they on any hormone therapy, all these factors you have to consider.
Okay, ma'am. When we are prescribing doxycycline, so is it like all the symptomatic patients should be advised for doxycycline?
No,
And
not
if you're
necessarily.
prescribing, how long should you prescribe it?
So doxycycline not only for all symptomatic patients, it's more on your clinical severity. If you see that it's a severe eye disease where you're seeing there's a lot of inflammation, then you can advise them. Even patients with mild disease would be symptomatic. So the symptoms in itself may not be a criteria, but when you see that it's moderate to severe disease, you advise them. One word of caution is not to be advised for children and pregnant females. And if you're advising them, usually I would recommend using them for 2 weeks and a BD dosing.
Yeah, the next question was that only, that in children who are like less than 8 years of age, how should we substitute doxycycline with?
So then I would recommend you can move to macrolides. Try to avoid tetracyclines if they are children. So you can use azithromycin like we discussed. Topical as well as oral formulation is available, and topical works very well.
Okay, ma'am. Then next is, what is like cyclosporin is not so easily available in all the centers. So what is the indication or the indications to start cyclosporin or any anti-inflammatory in case of in these patients?
So steroids you can use if you're not easily, cyclosporin is not available. Steroids can be used for short term. But if you're planning to, if you feel that the inflammation is such, it's quite severe and you're not able to control it long term with anything other than steroids, and you need some steroid sparing drugs, that is when you can use cyclosporin. It is not necessary to use it for all patients. Only if you feel that the patient now needs some immunosuppression for a chronic long term, then you can use cyclosporin. If that's not available, use short term steroids and then you can stop it as well.
Okay, ma'am. Then in a patient with recurrent chalcinosis, how long should we wait before undergoing or before taking the decision for INC?
For a patient with recurrent
Recurrent chalcinosis.
No, so that would depend on the patient also and the size of the chalcinosis, because some amount of swelling always remains. But if it's a very large chalcinosis, which is again and again getting inflamed and the patient is worried about the cosmetic part of it, you can do an INC for that. What
Okay.
I was talking about is that if there is a patient who keeps getting recurrent chalcinosis and you see that there are signs of blepharitis and MGD as well, then treat that first because that may be one of the causes.
Okay. Then when we are advising lid hygiene using baby shampoo, so in case of children, how should we maintain that? Because the parents mostly they say that no, it will go inside there, it's difficult. So
Yeah, it's difficult. Then you can advise them if they're so worried about it. Then you can just advise them to do it with plain warm water also. Works well if they're doing it properly. But if you can also counsel them that if the diluted baby shampoo, even if it enters the eye a little bit, it does not harm it in any way. But of course, if the parents are very apprehensive, just tell them to avoid the shampoo and do it with warm water. It's more important to clean it rather than with what you're cleaning it.
okay, and it's when we are using this baby shampoo, is it like like for how long should we keep it
No,
over
no.
the eyes, or is it just like we just wash it and just remove it like that?
No, so like I said, you can ask them to use the earbuds dip them in water which is being mixed with that baby shampoo. And just they need to scrub the eye with that and then scrub it with a clean bud. So you don't have to keep it on the eye for long.
Okay. In cases of like rosacea blepharitis or in posterior blepharitis, sometimes it's very confusing between the sebaceous gland carcinoma and to differentiate it with them because rose Bengal staining is positive. So
Yeah.
how to differentiate whether it's a false staining or it's a true thing?
So Meibomian gland dysfunction, if it's associated with rosacea, if you're seeing some findings other than the Meibomian gland dysfunction, you're seeing facial flushing and you have a doubt that it may be rosacea, then you can refer to a dermatologist, let them deal with the rosacea part of it. The MGD also improves.
Okay.
If you feel that the MGD keeps on worsening and it's not responding, then you have to have the diagnosis of gland carcinoma and then you'll have to take a biopsy for it.
Okay, and in case of elderly, like for young people, okay, we have a very lower tendency to think towards the malignancy. When we are talking about an elderly, and we get some of the cases which are bilaterally and like prolonged blepharitis, they present with and with the RB stain positive. So, is there can be a possibility of bilateral sebaceous gland carcinoma simultaneously in that?
Bilateral would be rare, but yeah, if you have a unilateral case, then I would say that you would have to keep it higher up in your diagnosis. If it is bilateral, maybe lower down, but you cannot completely ignore it. So if you feel that is constantly, it's there and you feel that there may be a suspicion, then it's better that you refer to an oculoplasty person, let them take a biopsy and then rule out carcinoma.
So, do we need to first give a conservative management to them in cases of unilateral, or should we directly send for
No,
the
you know,
oncologist?
obviously you will have to first conservatively manage them unless you see something like very typically loss of eyelashes or you feel
Hmm.
something is really carcinomatous looking, then that's different. But if you just see a case of blepharitis, not necessarily that has to be your first diagnosis. You will first manage it conservatively and look for response.
Okay, ma'am. Ma'am, there's a request from one of the student to explain the lipid flow mechanism once.
Okay, so LipiFlow has a warmer plate that when the apparatus is applied, so the warm plate gets heated up and it acts just like your warm compresses. The gland, the secretions inside the gland, they get melted. On the top, there is a cup. So that cup keeps giving pulsatile movements and they are vertical movements. So the melted secretions now because of the pulsatile movement start getting extruded out. So that is how it acts.
Okay, ma'am. There is another question which has come up now that apart from the Meibomian gland, if we talk about the Zeiss and the other glands, do they have a major role, or is it like always a Meibomian gland which is the culprit?
If you're talking about ocular surface abnormality, I would say the major role is the Meibomian gland. Of course, sebum from the gland of Zeiss and Moll's also has a role in the like I said, the immune defense and all that. But if you have a patient of dry eye, you are suspecting some ocular surface abnormality, then the main would be the Meibomian.
Ma'am, and also like clinically, can we make out on the slit lamp that okay, this gland is involved? It's the Zeiss gland, not the Meibomian glands. Basically, I think.
Based on the location, yes, Meibomian glands is more posteriorly located. As I said, it's just anterior to the mucocutaneous junction, and the pouting you can see. The glands and the Z's and Moll are at the lash follicles. So that would be one way of it, but there would not be any actually pouting that you see, but you can make out based on the location, which is the primary area of involvement.
Okay, ma'am, the next question is azithro eye drop equally good like an ointment?
Yes, now the studies have indicated that even the eye drops are equally working well, but I would suggest using the ointment because even logically, if you're dealing with a lid disease, the ointment has greater retention. And if the ointment is applied at bedtime, then the effect lasts longer.
Okay, ma'am. Then can tacrolimus eye ointment 0.03% be used in place of cyclosporin?
Tacliment, yes, it can be used. Again, one more issue here would be the stinging, which is quite severe. So many patients don't tolerate tacliment well also, but it is an option.
Okay. The next question is that most of the old patients have some degree of Meibomian gland dysfunction. Is there any criteria for proceeding to the cataract surgery, or if we want to postpone the surgery, then what is the criteria?
No, so some amount of Meibomian gland dysfunction would be expected. That's okay. But if the patient has symptoms, you see inflamed lid margins, you see erythema near the lid margins, then I would say that wait, treat the Meibomitis first, let the inflammation go down, And only once you have clarity from that, then you then you plan for the cataract surgery.
Okay, ma'am. The next is that what should be the follow-up of these Meibomian gland dysfunction patients after the treatment?
Depending on your treatment. So if you're giving them just medical treatment, I would say see them again in 2 to 3 weeks, because that's the minimum for the drugs to start acting, their eyelid hygiene to start acting. Of course, if you're giving them treatments like IPL, they have various sittings then. So IPL in itself would have 3 sittings. So you would anyway be seeing them according to the sittings protocol. So it's around first day and then 2 weeks and then at 1 month.
Okay, ma'am. I think this is the last question, that any role of Occupol DX, or when should we advise patients of Occupol DX?
So that is a steroid antibiotic combination. So the indication would still be the same. Like I said, steroid, if you're expecting that there's a acute inflammation that you want to tide over, then you can use it, and you can use it for around 2 weeks short term and then stop it.
Can it be substituted for ointment azithromycin, ma'am?
Azithromycin is said to be better because it has a dual mechanism, like I said, anti-inflammatory as well as the antibacterial. So it is a substitute in the sense it will have some antibacterial. If you're using it with the Occupol D, then it is a substitute.
Okay. One more question has popped up. Okay, when we say that Meibomian gland dysfunction or the blepharitis has resolved, is it just the clinical symptoms or anything else we have to look for?
No, you have to look for the clinical signs as well. You have to look for the erythema as well. You have to look for the pouting of the Meibomian glands. If you've used a Meibography before, do a repeat and compare it with that. So resolution means complete resolution.
Okay, ma'am. I think we have done from all the current sites. Hot seaters, you have any doubt, then you can directly ask, ma'am. Yes,
Ma'am, I have a doubt, ma'am.
Yeah, please.
Ma'am, is there a role of any cold compress in case of any eye inflammation? Ma'am, say it a blepharitis or a conjunctivitis. Is there a role of cold compression, ma'am?
In any inflamed eye, I wouldn't suggest. Cold compresses help in symptomatic relief. If the patient, like you're saying, some people do advise it for conjunctivitis because it causes some symptomatic relief.
Yes.
Yeah, but in blepharitis, MGD, we mainly advise them warm compresses.
So in conjunctivitis, which is preferred, ma'am? Cold compression or warm compression, ma'am?
Warm is not needed at all. But for cold also, it is just a symptomatic relief. It doesn't really have a major role to play.
Ma'am, then one more doubt is, what is the reason for more symptoms in the morning in case of an MGD, ma'am?
Because your lids are closed during the night. So whatever little bit of blinking in itself also has the blinking in itself is a force for the Meibomian secretions to come out during the day. So normally when your eyes are closed during the night, the secretions, they get matted up together, and because there's no blinking happening, the secretions are not coming out at all. So they all collect, and that is why they are worse in the morning.
The last one is, what is the risk factor for the Demodex infection, ma'am? Demodex mite.
There's no risk factor.
It's only the hygiene, right?
Yeah, it's only the hygiene. There's no risk factor as such, particularly.
Thank you, ma'am.
Anyone else? Saloni, Soni, any one of you?
No, ma'am.
Okay. Thank you so much, ma'am, for answering all the questions so patiently. It was such an awesome class to hear. And yes, ma'am, that's all for tonight.
Thank you.
Thank you, everyone. We'll meet again on Friday for the next class.
Thank you, ma'am.
Thank you.
Thank you so much, ma'am.